Good morning, everyone. Welcome to Presidential Lecture in Channel 1. I am Soonchunhyang from Yeungnam University in Korea, the president elected in Korean Lab Society. This session is a presidential lecture for current president, Professor Kyung. He is working for Soonchunhyang University in Korea, and personally, I met him 20 years ago in US. Both of us were in the exchanging professor program from the each university. I am Yeungnam University, and he was in Soonchunhyang University. So I'm always seeing his activity in our society. Unfortunately, 10 years ago, he resigned from his university and moved to the private clinic. But after 2 or 3 years, he decided to coming back to university. Soonchunhyang University accept him as full-time professor. So now we are seeing why the reason. So I always admire him, his activity, and his trial for our society. And today, his title is the treatment paradigm of type 2 diabetes. I want to add subtitle, treatment of diabetes, paradigm shift, medicine to surgery, and treatment to cure. And let's enjoy his lecture. Just start his video clip, please.
Good morning, ladies and gentlemen. My name is Kyung, and I'm working at Soonchunhyang University Hospital as a professor of surgery. It is a great honor for me to make a speech of presidential lecture at 46th Congress of Korean Society of Endoscopic and Laparoscopic Surgeon. Today, I'm going to talk about the treatment paradigm of type 2 diabetes. Paradigm is originally used in the field of natural science. First adopted at the book The Structure of Scientific Revolution by Thomas Kuhn in 1962. Paradigm is a perspective commonly accepted by most people during certain period. Paradigm shifting can cause the change of basic concept, leading chaotic confusion. Prime example of paradigm shifting was from geocentrism to heliocentrism. Historically, Copernicus' heliocentrism is opposed to Aristotle's geocentrism. Copernicus' opinion was rejected and he was persecuted during his lifetime, since people were unable to accept that Earth was a part of the world instead of the center. Who is in the center of the paradigm must undergo the tribulation. Here I have a question. What is paradigm of treatment of type 2 diabetes? Overall paradigm of disease is maybe the causal factor and or treatment principle. Diabetes is a chronic and metabolic disease characterized by elevated blood sugar, which lead over time to vascular complication. This is a document from World Health Organization. So, the paradigm of type 2 diabetes is care, not a cure at the moment. I read an interesting article from editorial opinion of New York Times, the newspaper. It was prediction of treatment of type 2 diabetes in near future. The title of the article is Surgical Treatment for Diabetes. It's editorial opinion. Some experts predict that the surgery will become a common treatment for diabetes in coming year. Before that happens, it will be essential to see how patients fare over an extended period and get a better fix on which patients are most likely to benefit from costly surgeries that always bear some risk. Okay. The point of this article is surgical treatment would be a mainstream in the near future. Prior to its application, safety and good quality of life should be guaranteed and the surgical effect should be permanent. If treatment paradigm of type 2 diabetes is a shift from lifestyle modification to surgical incretin release modulation. There may be gradual shifting of associated concept. Concept of causal factor evoked lifestyle modification such as sedentary lifestyle gradually replaced to erroneous response of human metabolic system to nutrient, which need surgical modulation of incretin release. Best treatment also change gradually. This is a kind of medical revolution. All the concepts should be changed gradually. The pharmaceutical revolution might be the biggest one. Hypoglycemic agents vanished gradually, and the research and development strategy revolve human intestinal hormone secretagogue or glucagon receptor antagonist. It is a chaotic confusion. Let's review the history of surgical management of type 2 diabetes. The beginning of a paradigm shift was maybe the discovery of incretin at 1932. Idea of close relationship of gut and diabetes began to bear bud. At the last 1995, first description of surgical effect to type 2 diabetes is described by Dr. Walter Poyes through his interesting article Who Would Have Thought It at Annals of Surgery. 10 years has passed. At last, Dr. Rubino claimed the forward hypothesis. At the time, type 2 diabetes was expected to be exterminated within a couple of years. However, researches and trials are still ongoing for 15 years until these days. As a result, there had been increased number of doctors doubting the cure through the surgical intervention. From this slide, I'm going to show my personal history of diabetic surgery. It was 2009. I started metabolic surgery with a modified mini gastric bypass. Now the procedure is called single anastomosis gastric bypass. Total 183 subjects whose BMI was less than 30 was targeted. The mean BMI was around 25. The outcomes were acceptable in terms of anti-diabetic effect and surgical safety. Hypoglycemia was controlled more than 80% without recurrence, and there had been no mortality or severe complications. The mechanism behind such an excellent outcomes were expected due to the complete forward exclusion from nutrients, with the fed diet delivery of nutrients to distal intestine. Incretin response against the surgery was more than expectation. 1 month after surgery, the fed incretin GIP was down-regulated above half level compared to previous pre-operative value, and the good incretin GLP-1 increased up to 3-fold. These outcomes were comparable to biliopancreatic diversion, but quality of life can't be compared. But unwanted complaints from side effects began to appear over time. They had minor GI problems such as dumping syndrome, bileprous gastritis, marginal ulcer, and so forth. They don't make any problem at the beginning of the surgery, but patient complaints were getting heavier with tedious and annoying symptoms, which is permanent. But more seriously, undetectable gastric cancer of bypassed segment of stomach was make my patient crazy. Actually, there is a minimal possibility to develop of new gastric cancer at bypassed segment, but problem was our bad memories from our ancestors suffering terminal gastric cancer, because our country was an endemic area of gastric cancer and most cases were already advanced. Surgical approach of metabolic syndrome has been hindered with these obstacles. Get through these obstacles, modifying the procedure was inevitable. Resectional gastric bypass or just leaving the entire stomach is one of exit strategy. but there was no substitute for the pyroric sphincter function. While I concerned with it, I found very interesting mechanical fact never been discovered yet. Furthermore, breakthrough against the technical obstacle was a custom one for me. So I didn't hesitate devising a surgical technique and put into practice. It was December 2015. New modified procedure was conducted on the three principles. For the better gastrointestinal quality of life, pyloric sphincter has been preserved. Maximize the antidiabetic effect. More than 200 cm of biliopancreatic limb has been reserved. And finally, anti-duodenum was excluded to avoid recurrent. Another name of this procedure is the total duodenal exclusion with pyloric sphincter preservation. The procedure was very simple and can be done within an hour. Procedure begins with under the laparoscopic vision. The first portion of duodenum just distal to pyloric sphincter is transected with a linear stapler. Tagging suture between the distal stomach and the small intestine 200 cm distal to triton ligament is made, and the operative field is exteriorized. Then the 5 cm incision in the subxiphoid process was made, and the anastomotic area is exteriorized, and the interrupted suture anastomosis was done by direct vision. Outcomes of this surgical technique are not published yet, so this is not approved data. So I just let you know the important information. The characteristic of this procedure is weight loss from surgery was negligible. There was no weight loss. And the post-operative GI quality of life was excellent. And comparing two group of BMI more than and less than 25, surprisingly, better outcomes are evident in low BMI group. Now it's time to discuss supporting evidence and the reference about the cell migration and the necessity of a long biliopancreatic limb. Prior to start the discussion, there is something to be sure. First, recently GIP is reappraised as a primary cause of type 2 diabetes. Second, the metabolic role of glucagon is being re-evaluated and expanded beyond its counter-regulatory role and the prevention of hypoglycemia. Third, targeting to GIP and glucagon release is highlighted recently. This table shows incretin conversion after individual surgical procedure. As you know, BPD is most potent metabolic surgery. BPD is the only procedure curing metabolic syndrome. This is one of evidence that the involvement of GIP to type 2 diabetes pathogenesis. Evidence of epithelial lineage migration has recently been described. The single-cell analysis has revealed regional reprogramming during adaptation. Watch the figure in right side. The bowel can be divided into part C and part D. C and D has different lineage. If the A and B line is transected, then the distal margin of C and with the proximal margin of D is connected with the anastomosis. There is a gradual change of D area to C-type lineage. Historically, there had been trials to avoid surgical complications. To avoid GI trouble, pylorus exclusion procedure tried to include pylorus sphincter function. Let's see the outcomes. The prime examples are biliopancreatic diversion to duodenal switch or BPDDS and pylorus exclusion DJB to pylorus preserving DJB. This slide is biliopancreatic diversion to duodenal switching. According to the literature, BMI reduction and the weight loss were not large. Patients who had severe long-standing diabetes need a second operation of the classical BPD because of failure in improving diabetes. Another patient was changed to classical BPD because relapsing chronic duodenal ileal ulcer. This is a figure of Paro's exclusion DJB and the Paro's preserving DJB. Both procedure has advantage and disadvantage each other, but the Paro's preserving DJB has recurrent symptoms in most cases. This is outcomes of both procedure. We can clearly find that the recurrent pattern in the Paro's preserving DJB group. On the contrary, Paro's exclusion group does not. I think this slide is the most interesting slide. Three kinds of subtype of DJB can be compared each two different procedures. This procedure brought us a lot of mechanism of action. First, acceptable outcomes in two cases. Second, duodenal mucosa exposure to nutrient in two cases, but among the exposure group, recurrence was only one. The possible answer is surgical Paro's preserving DJB. Duodenal tissue can be crossed over the anastomosis line to jejunum. At that time, the jejunum is under the compensatory proliferation. This compensatory process promotes duodenal tissue proliferation. On the contrary, duodenal jejunal liner installed and the barrier prevent cellular migration. Therefore, duodenal tissue proliferation is difficult. Lots of evidence is same migration from published articles. For example, after ileal transposition to jejunum in the canine experiment, ileum was jejunalized, both functional and structural, with morphological and histological. And another one is 3 to 6 months from surgery is necessary migration with proliferation until noticeable symptom of the recurrent hypoglycemia, increasing blood glucose level persists almost 12 months after surgery. It is same as a compensatory proliferation of small intestine after massive small bowel resection. Conclusively, missed determinant for outcome of metabolic surgery is proximal lineage can cross over the anastomosis line, and accompanying compensatory proliferation could promote replacement of cellular identity. Okay, let's discuss over the importance of the biliopancreatic rim in metabolic surgery. There is a little difference between the RU and the BP rim is very important. Most important thing is mechanism of the nutritional absorption and the incretin release is different. Without digestive enzyme, nutritional absorption is disturbed. On the contrary, incretin release is possible without digestive enzyme. Strategy of metabolic surgery is down-regulating of GIP secretion and avoid nutritional absorption deficiency. Recommended site of exclusion is sharp decline of KSA population. Length of bypass is depend on the individual situation, but 200 cm from thoracic ligament area is proper area. This figure make it easy understanding of relationship of GIP alteration and BP length. The major determinant of metabolic outcomes of surgery is completed duodenal exclusion and length of BP rim. In Ruai gastric bypass, duodenal exclusion is always perfect in every case. So the length of BP rim suggests make it possible metabolic outcomes of surgery. So to speak, renal gastric bypass for metabolic surgery, long BP limb is very effective. More surprising fact is post-operative GIP alteration is negatively correlated with the length of BP limb. So to speak, there is a relationship between the biliopancreatic limb length and the GIP alteration. And the GIP alteration has a relationship with the metabolic outcomes. That meaning is length of BP limb has a relationship with the metabolic outcomes. The comparing metabolic outcomes and the length of BP limb showed very interesting data. The 30 cm BP limb length, there was a paradoxic hypoglucagolemia. The 100 cm BP limb length diabetes remission was 25%. And finally, the 250 cm BP limb length promote reversibility of type diabetes. In this table, satisfying every determinant is biliopancreatic diversion only. That's why BPD is the most effective metabolic surgery. Meanwhile, powers preserving BPD does not satisfy all determinants. Therefore, metabolic effect is not very good. Duodenum is definitely excluded in renal gastric bypass. But the length of BPD is inconsistent. That is the reason why post-operative GIP value is inconsistent. But we can validate metabolic effect of BPD length because duodenal exclusion is perfect in every case. Conclusively, GIP glucagon length of BPD is close relationship and very important. Okay, this is the final slide. Take-home message. We have missed an important determinant of outcomes for metabolic surgery. First is compensatory proliferation and hypertrophy of remaining small intestine, and change from distal intestinal epithelium to a functional identity after resection anastomosis of small intestine. These are most important things, and there are two major determinants for metabolic surgery outcome. First is total duodenal exclusion, and the second is length of BP limb. Thank you very much for listening.
Thank you, the lecture from the Kyung Hall. Do you enjoy the lecture? And then usually after presidential lecture, we don't have the question and comment, but try to remember his name in English. So try to his information and the content again in the social network system. After putting his name in Google website, the result I want to show you here. Do you see? And try to remember his name in English, and then in outside of our country can put his name in the Google site, and then you can easily find the result. And then I want to invite Professor Kyung Her, current president of our society, last summary or comment. So, would you give us some kind of message, Professor?
Okay. Yeah. Can you hear me? Can you hear me?
Yeah, we can hear you.
Okay. I am Kyung Ho, and thank you very much for watching. I think there may be a lot of questions and comments. As you know, my presentation is very sensitive and debatable. But limitation of time, it is difficult to answer every question. please use my email something. And I hope my presentation contributed advancement of metabolic surgery. Thank you again your interest and joining us together. Thank you.
Yeah. Thank you, Professor He. Because of time limitation, we're going to close presidential lecture. Thank you, everybody. Bye. See you after that.